I feel like I'm bubbled from you guys. Okay. Thanks, Robo Lady. Okay. So minimize this. All right. So you guys are stuck listening to my grand round. And so I thought I would focus on molecular updates, right? So the CNS tumors just issued their new WHO book, which is all molecularly based now. It's totally overhauled. It's doubled the size of the book. The WHO for the eye tumors hasn't come out yet. You're still in the 4th edition, but I would envision that this is where the practice is going. So I figured, since I was already kind of beefing up the CNS molecular ones, I figure I'd do an update for you guys about molecular findings in ocular tumors in general. Because this gets CME, I have to give disclosures. And so I have no financial disclosures, but clearly I have other disclosures, and the lack of filter is very real. The need practice gap, right? So molecular medicine is really changing how we're taking care of patients, right? It's giving us prognostic information. It's changing treatment therapy regimens. So we're really, then the technology is just booming. And so it can be really hard to keep up with these things, even as a pathologist. There's a whole subspecialty training in molecular pathology, which I do not have, which is a 1 to 2 year fellowship just to try to keep on top of these things. We have molecular pathologists that I rely on very heavily, but I at least can triage things to some extent. But if it's hard for me to keep on top of things, I think it would be impossible for you guys to, on top of everything else. So that's why we're here. So I'm going to do a real brief primer on molecular testing that'll probably throw you back to medical school, but I figure it's probably important. We throw around these terms a lot, and I'm not sure that most folks know, like we hear next gen sequencing all the time, but what it actually means. It's probably good to have some kind of context. And then I'll review the frequent molecular findings in ocular tumors, and then we'll apply it to kind of make a workflow that is sensible and logical, if that makes sense. And there's your expected outcome. Okay. All right. So there's 6 big parts on this. So again, the molecular primer, and then I'll go through the big kind of tumor categories that we have. And then I'll finish talking about liquid biopsy. That's something that kind of, it kind of comes and goes in popularity. But I think particularly with ocular tumors, since you guys, there's a difficulty in sampling the tumor, unlike in other areas, that liquid biopsy may prove in the future to be quite useful. So molecular techniques, these are really broken down into true molecular and cytogenetics. So we've had cytogenetics for decades, right? So that's actually looking at the chromosomes, spreading them out into a karyotype, which you can see here. And nested within that are FISH studies. Okay. And then the molecular genetics are all the PCR-based testing, the sequencing. We can look at epigenetic changes. We can look at RNA sequencing as well. So on a much more granular detail. We've been doing FISH for years. We have a FISH lab. It's very, very good at what it does. It revolves around involving a known gene. So we know what the gene mutation is. We have an idea. We know what the tumor type is. And so then we can figure out what the gene mutation is. We take fluorescent probes. The probes can be quite large, up to 200 kilobases. And usually there are going to be 2 probes. You're going to see green, which is typically the control probe. So we stick it on a centromere. And then red is your target probe. A normal signal should have 2 of both, as that makes sense. But we can use it to look for loss, like in 1p19q codeletion loss, right? So you've got 2 control signals and 1 red signal. You can look at for fusions like BCR-ABL with leukemias, where the red and green kind of fuse together to make a yellow. And then we can use it for amplification. So this is EGFR amplification in a tumor. And so you can see there's more than 2 red signals there, just slightly. It definitely very much still has its place. And it's very fast, it's very reproducible, but it is requires a lot of technical kind of upkeep on the behalf of techs and growing things. But then in 1983, lots of things happened. Many of you probably weren't even born. But so, you know, Reagan, and I spelled Reagan wrong, but that's okay, initiated the Star Wars program. Super Mario Brothers was released, right? Motorola, the first phone, look at that, the first mobile phone. Cabbage Patch dolls, for all the rage. But for this talk, PCR, That's when PCR came out. And this just really blew the doors wide open for molecular testing, right? So you take a primer, you have a sequence of itches that you like. It can be a teeny amount. And the primers, you denature it, you stick the primers on there, you have a DNA polymerase that makes more copies of it, and then you do the whole cycle all over again, and it grows exponentially. So with very little tissue, with very little tumor DNA, we can get a ton of information. We still use cytogenetics, like I said. PCR doesn't work for everything. If there are large deletions, if there are duplications, complex rearrangements, or amplifications, the PCR is not going to work for that. And that is why cytogenetics and fish studies still are in use today. They're also faster, they're focused, they're cheaper. But you know, we now have more molecular tests based on PCR than Baskin-Robbins has flavors, right? Like there's a bazillion different variations. Sanger sequencing was the first one. It actually came out a little bit before PCR, but required so much DNA that it didn't really get traction until PCR allowed you to make big volumes of DNA that you could then sequence. For me, Sanger sequencing is essentially like the infinite monkey theorem, right? Like if you put an infinite number of monkeys in with an infinite number of computers, they'll eventually bang out the works of Shakespeare, right? And so Sanger sequencing, you throw a bunch of nucleotides in the jar. You also have some stop nucleotides. And so eventually you are going to one by one sequence the DNA with every possible combination, and every single step of the way you'll hit a stop codon, right? Like if you think it's randomly pulling nucleotides and sticking it on there, it's going to randomly pull one of those stop nucleotides and give you a short string. And then you'll get the one that adds all of them but the next one, and then the next one. So you end up getting the entire thing sequenced, and then you run it on a gel, and then you can follow the size of the gel and start from the very top, right, as the biggest one, and go all the way down to the bottom. And so you can essentially be like C-A-G-T. Okay, so it has its current uses, very much so. So this is how a lot of public health centers are sequencing the COVID spike protein and figuring out which variant is running around. We do a variant of this known as pyro sequencing, which sounds more awesome than it is. And that is for IDH mutations as well. But like I said, there's infinite other ones. So if you know the mutation, the big one here is BRAF's B600E, right? That's the big melanoma mutation, among other things. And all you need, it's a very specific mutation that happens at that 600 spot. Then you can do this single base primer extension where you can just look for what happens at that one spot. You add a base pair and it'll tell you exactly whether or not it's normal or mutant. Very fast, very cheap, and very efficient, right? Some of these things like general sequencing take forever. So if you need a fast answer for your patient and this works, this would be the testing route to go. You have restriction fragment length analysis, amplification length analysis, which is good for like your trinucleotide repeat disorders, right? That's how we diagnose Huntington's or those other kind of repeat disorders. And then you can do real-time PCR as well, which is great for infectious loads and minimal residual disease techniques. Other ones you may hear about, so comparative genomic hybridization and SNP analysis. These are when we don't know what the gene is, we can compare it to a normal and see which ones pop out as not being normal. And then we're like, oh, okay, well then you look at the disease, you look at the family history and see if you can figure out and pull out and see which genes it might be. And then we can do epigenetic surveys as well, right? So methylation studies, particularly on DNA. You can look at histones as well. We've been doing MGMT promoter methylation studies for glioblastoma for quite some time. But as you read, if you read the new WHO for the CNS tumors, which you must be really bored if you would, but DNA methylation profiling of these tumors is where they're going to subclassify all of these tumors. And so this kind of testing you're going to see only get more common as we go through. We don't do it in-house. We have to send out to do that for right now. I haven't seen much of that in the literature for eye tumors yet, but I'm sure it's coming. You guys just have such a smaller volume than what other subspecialties have to play with. But next gen is really the one that everyone loves, right? It's more sensitive than Sanger sequencing. You can take heterogeneous samples. So they figure out a way to break all, if you look at a tumor, right? They're really heterogeneous. They have a like initial triggering mutation, and then all the little clones make subclones, and they all kind of spin off on their own pathways, right? So you have a really, and that's if you get pure tumor. Then if you throw normal stuff in there as well, you can imagine that if you grind that up and look at the DNA, it's going to be all over the place. The neat thing about next-gen sequencing is they somehow figure out ways to tease out each of those strands and look at them individually. So this is a high throughput, massive parallel sequencing. And so that's why you can use heterogeneous tumor samples. And it's really become a great way to look at tumors because of the heterogeneity of tumors. You can look at hundreds of genes at once when you run one test, which is really, really helpful, both in research and now moving towards therapeutic interventions. It's expensive because of course it is. It will miss larger deletions and gene rearrangements. So again, cytogenetics is not going anywhere. There's lots of different variations. So you can choose to do just single gene sequencing this way. So that's like folks who have cystic fibrosis. That's a good way to look at that. It's a big gene. It's very complicated to do targeted sequencing. It's better just to sequence the whole thing. Gene panels are probably most common and what you're going to see. So Caris and Foundation One are are next-gen sequencing platforms that you've probably heard of, maybe. And so they'll typically give you a printout with hundreds of genes that show mutations or not. And so that is probably the most common reports that you're going to see. Then there's whole exome sequencing, which doesn't sequence the introns, right? It just sequences the like important bits, which is about 1.5% of the genome. These are predominantly on research, and then you could sequence the whole darn thing. It's super slow. And the amount of data that it generates to try to look at the entire genome on like any kind of practical basis requires a lot of informatic structure that most folks just don't have the bandwidth for. If you think about an entire genome is somewhere between 2 gigs and 4 gigs of space. And that's just with, that's not like a digital slide because that's about the same size as a digital slide. I mean, you think about the amount of data that is when it's just a base pair, right? Like over and over and over and over again. It's just mind blowing. So that's kind of the big one. So Foundation One is the big one that it was the first one to get FDA approval for the solid tumor CDX. You'll now see that most of us order the heme sarcoma panel. So much like everything, once you get the FDA involved, it becomes super regulated and their solid tumor panel was locked in. So they couldn't change it. They couldn't adapt it. They couldn't update it without reapplying for approval. So that's why the heme sarcoma panel came out. And so that's the one that really grows as they find more applicable genes. They can change that panel and increase it up. There's liquid CDX2, which looks at mostly blood. Or other fluids and can give you things up to 300 genes or so, mutational burden, and most of these will also tell you whether or not they're microsatellite instability. Cost is not an insignificant thing in molecular testing. So the cost of this is almost $6,000. The patients don't usually see that because Foundation One has figured out a way to offset it by selling their data. Woo! So most people end up paying up nothing. And a small percentage will pay up to $100. So for now, we'll see if that changes. Caris, I think we like a little bit better for several reasons. It does tissue microdissection, so it tries to get a cleaner tumor sample and doesn't mix as much normal in. They do whole exome sequencing. They report out gene panels, but they have that data always there, so they can always go back as new genes surface. They can go back and kind of look at that data. It's all there. It's just kind of hidden and pull out and see if they have these gene mutations as they grow. Right now, they report out about more than 600 genes. They'll tell you if it's microsatellite instability. They'll tell you what the tumor mutational burden is. If there's loss of heterozygosity, they can tell you what the HLA status is. So the entire whole exome sequencing is researched now, but like I said, you'll get a gene panel. They are working on backwards creating a karyotype like cytogenetics, so they can do this digitally. When that goes live, then suddenly you don't need to do cytogenetics to get an array. We'll be able to diagnose 1p19q on this panel, which is pretty cool. Still in early stages right now. It's a little bit cheaper than Foundation 1. And then it's really covered by insurance, and then UK will eat that cost. So most patients, if it's not, so most patients pay anywhere from, most pay $0 up to $45. So, so that's kind of a primer. I'm sure you guys are all molecular experts now, or you got a good nap. Either way, it's fine. Surface lesions. So really we're talking about conjunctival lesions. Squamous, there's not really any current molecular testing to do with these guys. We will see, if you scan them, oftentimes you'll see UV related damage, right? That doesn't surprise anybody with squamous lesions. We have seen they report TERT mutations in 44%, but there doesn't seem to be a prognostic significance for those. Overexpression of P16 can be associated with high risk morbidity and mortality. Now, whether or not, they don't recommend to routinely stain these. The P16 is typically in squamous lesions linked to HPV changes. I don't know that I see a ton of HPV changes in the eye, and whether or not how much you guys do as well, but I would imagine that that's where that comes from. Loss of retinoblastoma genes, as you can imagine, is always bad. And they're working on transcription profiles for these lesions, which seems promising, but it's still experimental. So it's all H&E diagnosis right now. Melanoma. So this is conjunctival melanoma. This is more similar molecularly to skin melanomas and not to the uveal melanomas, which we'll talk about later. There's 4 major pathways. So there's BRAF mutated, which is the bulk of them. There's NF mutated, RAS mutated, and then none of the above, right? So BRAF tend to be younger patients. It can arise in a pre-existing nevus. Doesn't seem to have a prognostic association, but then they've been studying, of course, anti-BRAF therapy for those folks. Literature is kind of a mixed bag on whether or not how much that helps. NF1 mutated is also UV associated. These are known to have high mutational burden, and they seem to be responsive to PD-L1 therapies. So, and then the RAS mutated, so it's usually an NRAS mutation as well. Don't know much about those other than there's no directed therapies that I know of right now for that one. So there's not, for conjunctival melanoma, there's not really any current suggested testings. You could wonder if BRAF and PD-L1 staining might be helpful in the future. We're staining PD-L1 in a lot of tumors. I have a feeling it's going to go forward here as well. Hematolymphoid stuff. So lymphomas there are about 80% are going to be primary to the conjunctiva. Most of them are this marginal zone, it's maltish kind of lymphoma. It's a low grade B cell lymphoma involving the NF-kappa B pathway. The MYD88 mutation, which we'll see more in retinovitreous lymphomas, does seem to have a poor prediction here as well. And you can see, you can always get a smattering of lymphomas, right? Like it's never just one lymphoma. But by far the most common is this extra marginal zone lymphoma of mucosal associated tissues. No current testing other than the typical routine heme diagnosis for these lymphomas, right? So we subtype them and follow them according to the WHO for heme. So there's been no recent changes with that one. Intraocular lesions. So retinoblastoma, this is the quintessential 2-hit hypothesis. We learned this in medical school. It's still the same, still really important. It's a tumor suppressor gene. It blocks movement from G1 to S phase in the cell cycle. It binds to transcription factors, doesn't let them work. With loss of that, the transcription factors can go on their merry way and cause a lot of growth, movement into the S phase, and then they can have an unchecked S phase and just keep growing and growing and growing. There's a lot of, we always have compensatory mechanisms. The problem is there's certain areas like the retinal cone precursors that don't have those compensatory mechanisms to kind of counterbalance that. And so that's why with retinoblastoma, why they grow retinoblastoma, because they don't have compensatory mechanisms. You lose the RB1 gene, and then it goes forth into S phase. Lots of mutations downstream, right? It's not just that. These are heterogeneous tumors. You can see mutations in all of these oncogenes. So they get gain in function in the oncogenes, and they get loss in the CDH11 tumor suppressor gene, and ultimately leads to retinoblastoma. Very small percentage are not RB1 gene mutated. Those seem to be driven by MYC. which is always bad. Any MIC amplification, I've never seen like, oh, this is a good MIC amplification. So if you're on an exam or your patient unfortunately has a MIC amplification, you can assume that that's probably bad. So a very small subset of these retinoblastoma cases will have MIC amplification instead. Current suggested testing is less about the tumor and more making sure the kiddo doesn't have a germline mutation, because then you'll have to test the kid and then you'll have to test the family, right? And it becomes a whole big thing. So that's really the big focus. For the initial patient, you can do next gen sequencing to figure out what the mutation is. And then it's probably cheaper and faster to then, when you know the mutation, to use Sanger sequencing to focus in on that for the extended family. And figuring out who has what mutation. Important thing to remember, if you have a kid with retinoblastoma, you think, especially if it's bilateral disease and they come back negative for the next gen sequencing, always remember that large mutations may be missed by that. So they still might have a germline mutation. It just might be a really big loss, of large mutation. And so in which case, if you still suspect it, even after next gen sequencing, feel free to reach out to your friendly pathologist and see what other methodologies we can do to make sure that patient doesn't have germline mutations. You can also run next gen sequencing on aqueous humor if necessary for diagnosis. And that gets more towards like the liquid biopsy kind of thing that we'll talk about later. Medulloepithelioma is supposedly the second most common intraocular tumor within the first decade of life. I've not yet seen one in person. Has anyone here seen one? Bueller? No. But so it looks very much like a small blue cell tumor, has the beautiful rosettes, either the Homer Wright type rosettes that we see in something like medulloblastoma, or the immature kind of true rosettes like the Flexner-Wintersteiner ones that we see in retinoblastomas. So all the blastomas love to make rosettes. They can be teratoid or non-teratoid, where they have, when they're teratoid, they have stuff that shouldn't be in the eye, like cartilage, like bone. The reason I bring these up is because they're known to have Dicer1 mutations. So Dicer1 is a new kid on the block. We're finding that there's a lot of syndromic tumors that can have Dicer1 mutations. It helps in microRNA formation and somehow leads to tumor formation. There's a familial pleuropulmonary blastoma syndrome. They have lots of different tumors, and about 1% of these families will also have medulloepithelioma. There's a Lin28A mutation as well, which silences tumor suppressor microRNAs and allows tumor formations. Who knows, right? Like the genetic testing on this, it's a pretty rare tumor. And so if we're wondering if we get a sample of it and it's a small sample and I don't have something that's quantitatively knee-jerk, this is clearly retinoblastoma, this is clearly medulloepithelioma, a Dicer mutation, the retinoblastoma mutation could certainly help with that. And then the Lin28 ultimately feeds into the mTOR pathway. So an mTOR inhibitor, maybe, who knows? Right? We just need more statistical N to see how that works. So other intraocular lesions, so lymphomas, these are non-uveal lymphomas. So this is really your primary vitreoretinal lymphoma. This is really a subset of primary CNS lymphoma, right? So about 2/3 of these will have just ocular alone, and up to 1/3 will have CNS involvement as well in the brain. They typically are non-germinal center phenotype. So this activated B cell, about 15% will be unclassifiable. And then often a small subset can have MYC alterations as well, as you can imagine, which would be bad. The diagnosis for these guys can be quite difficult, right? Like, so we're used to diagnosing lymph nodes, which can be upwards of several centimeters. And you guys are dealing with very small volumes of aqueous humor or vitreous from your vitrectomy specimen. So we recognize that. And so it's a diagnostic challenge. So we either get vitreous from you guys or maybe even a chorioretinal sample. And there's several things we can try to do with that small amount of tissue and fluid. We can do IL-10 levels. And so IL-10 levels are markedly elevated, way higher than you see in uveitis. And so a level over 30, whopping 30 picograms per milliliter, or you can do an IL-10, IL-6 ratio in some of the fluids, kind of allows you to make a presumptive diagnosis of lymphoma. You can also do the CSF levels, the IL-10 levels, and that's been shown to have decreased disease-free survival. If you're lucky, you can try to do heavy chain clonality by PCR as well. And then the big one that we often send for is the MYD88. So this is a protein that's involved in interleukin signaling as well as toll-like receptor signaling. So that's the NF-kappa B pathway for all of you that I'm sure remember that. This increases the sensitivity of vitreous analysis markedly. About 70% of these lymphomas are going to show this mutation, and it's a PCR-based study, so you need very little tissue and in order to get it, to have it done. If we've got plenty of tissue, sure, we'll send it for cytology, we'll send it for flow cytometry, which are our older techniques. But really, when you're parsing out very tiny amounts, the MYD88 mutation tends to go first. We haven't had great luck sending out IL-10 testing, but you certainly could do that in the aqueous as well. And then we usually do the MYD88 and flow are the kind of the big two, and then cyto if we can manage it. Future directions, you know, there may be some targeted therapies in the future. Systemically, the WHO is working on subtyping diffuse large B cell, and there seem to be 4 molecularly identified subgroups that may or may not have some prognostic significance. That's still debated in the literature by the heme folks, and so I'll let them hash that out. But I would imagine that's eventually going to come for you guys as well, right? Once they figure it out systemically, it's going to move towards CNS lymphoma. And then the vitreoretinal lymphomas as well. And then there's some protein markers as well. So they wonder about osteopontin levels. So if you have high levels, that might be bad with worse survival. But again, this is all still in the research realm. Everybody doing okay? Yes, okay. UV lesions, right? So melanoma, most common primary adult intraocular tumor, can be anterior or posterior. And these nasty buggers can have really late recurrences, right? So they can be 10 years out and think that they're fine and then suddenly pop up with a met or local recurrence. And up to almost half of these patients will die with metastatic disease and within 15 years of diagnosis. And what they think happens is that they actually think there's some dormant melanoma cells that flake off and are circulating way before you even diagnose the primary. And then something triggers them afterwards to kind of grow into their metastatic disease. There's extensive research going on with trying to track these tumor cells. This is where liquid biopsy comes in, which we'll talk about in a little bit as well. But it's a really sneaky lesion. The vast majority are posterior, right? So they're choroidal or ciliary body. The cytogenetics that are important to know are monosomy 3, AQ amplification, and we can identify those by a vast majority of things. So we use FISH to look at monosomy 3 and the 8q as well. There's certainly other ways to look at that. Gene expression profiling, which is actually mRNA sequencing, is becoming the new kid on the block as well. It's better at identifying high risk factors than our patient populations. And so it kind of separates them into risk classifications. So low risk of metastasis, that's class 1A, intermediate risk is a class 1B, and high risk, which often associates with monosomy 3 and another mutation, BAP1, that I'll talk about in a second, tend to fall into this class 2 with a high risk of metastasis. Despite its evilness, it's actually a relatively stable genome in the tumor. So it doesn't have a lot of microsatellite instability. It doesn't have numerous recurrent mutations, which is interesting. It does seem to have an initiating mutation of either GNAQ or GNA11. I didn't name any of these, which ultimately leads to an overactivation of the MAP kinase pathway. And so you can test for either one of those. So that's one of the first mutations that happens. So it's pretty conserved no matter what subclone you're testing. If you don't have either of those, it's called a double wild type, and there's like a handful of other ones. Ultimately, it all feeds into the same pathway with MAP kinase overactivation. Prognostic mutations, the big one to know about, and the one that we're now testing for is BAP1. So that's BRCA-associated protein 1. It's on chromosome 3p. It's involved in chromatin dynamics. About 84% of metastatic melanomas have a single mutant copy of this. So they lose their good copy. It's on chromosome 3, right? So they get monosomy 3, which is bad. They lose their good copy of this gene, and then they're left with the 1 mutant BAP1. And so up to 8% of the folks supposedly in the literature actually have a germline mutation in BAP1. So you can imagine that they're going to have other cancers as well with that same kind of cancer mechanism. Again, that kind of 2-hit mechanism. These tend to met very early. And so now we can send this out by immunohistochemistry. It correlates very well. And so we send this off to Mayo. We get a slide back, and I'll read it out and give you a BAP1 result on your melanomas. The non-BAP1 mutant cases, you can see there's a couple other ones that are either involved in splicing, which can be a problem, but tend to be late Mets, or this EIF1AX, sounds like a password, which ultimately is a low risk. So it falls into like the type 1 tumor group, and they tend not to have mutations at all. Unfortunately, or not to have metastases at all. So, these can definitely help you guide your patients with prognostic. And so the BAP1 is the big one, and that's why we're doing it now. Anterior uveal melanomas. So these tend to be a little bit less aggressive. These are super hard to sample, right? Like with the sitting in the iris. The metastatic rate is up to 10% or so if you follow these patients outwards of 20 years. The genes profile, again, you have a class 1, class 2, low risk, high risk, but they tend to be a little bit lower risk for metastases than the choroidal melanomas. You can occasionally see some of the cutaneous type mutations, so the BRAF or the NRAS mutations as well, but a little more, certainly less common, and so probably less well-known and tested molecularly. So right now we'll send out for both monosomy 3 and BAP1 to try to give you guys some kind of idea for your uveal melanomas. I would wonder if RNA sequencing is going to be like RNA-seq is going to be in the future as well. The literature is talking about that. We do that with some of our CNS tumors. Uveal lymphoma. So this is not typically associated with CNS, right? Diffuse large B-cell lymphoma. This is it tends to be its own entity. It's usually a B-cell lymphoma, as most lymphomas are. Your first step is to make sure it's not systemic with secondary involvement of the eye. Somewhere between a quarter to a third of these will have systemic lymphoma as well. You guys can magically do a uveal FNA and try to stick and get tissue sampling. And most of these, kind of similar to the conjunctival epithelium, most of these are an extranodal marginal zone lymphoma. So not the diffuse large B cell. That's certainly secondary, but the majority of these are the marginal zone. And then they get the typical heme workup. There's nothing special for these other than the heme full court press. And then Mets. So supposedly upwards of 10% of patients that have systemic Mets will also have ocular involvement. And it's the most common intraocular tumor overall, not primary. Most of these are in the choroid by far. Breast and lung are our two big culprits. And of course, we have a lot of both patient types here, unfortunately. And the suggested testing right now just bases on what the primary is. Many of these tumors are getting PD-L1 testing to see if there's testing that way. Of course, we try to subtype it and figure out where it's coming from in the first place. And so whatever the systemic issue is really what drives the testing and therapy follow-up for those. Last of the different subtypes, kind of talking about a couple of the lid lesions and sarcomas. So for the lid lesion, the kind of unique one here is, of course, sebaceous carcinoma. These are mostly on the upper eyelid. They can be nodular or pagetoid forms. If you do whole exome sequencing on these, you'll get 3 subgroups. So there's UV damage, there's microsatellite instability, which is are your Muir-Torre patients, and then there's none of the above. Another paper suggests the possibility of maybe HPV being involved in these tumors as well, but that's still under investigation. Muratore, I don't know if it shows up on your boards like it does on ours, but it's very common to pop up. And so it's important to know about. This is a variant of Lynch syndrome, right? The microsatellite instability syndrome. We are in a Lynch pocket here in Kentucky. And so it's important to kind of think about this. We do have Muratore patients that come through. To diagnose it, you need one sebaceous neoplasm or keratoacanthoma, and then one Lynch-related cancer, which is pretty much all of the big organ, like organ systems, right? Colon cancer is very common. Endometrial cancer is very, very common in these folks. They're probably the two biggest ones that we see. It's an autosomal dominant. It's got high penetrance, right? And it's due to mismatch repair gene mutations. The most common combo is to lose MSH2 and MSH6, but there are other combinations there. And there are other genes that are under investigation as well for sebaceous carcinoma outside kind of the Lynch syndrome, and you can see them listed here. Interestingly, PD-L1 positivity seems to be associated with a high expression with metastatic disease. So whether or not PD-L1 testing becomes standardized in sebaceous carcinomas, we will see. Currently, for any sebaceous neoplasm, they recognize you screen for microsatellite instability, and that can start the Muratore syndrome. And then again, maybe PD-L1, maybe HER2 testing as well. We test HER2 in breast most notably, but other tumors as well. And then there's oodles of sarcomas that can happen. I focused on rhabdomyosarcoma just because it's the quintessential orbital sarcoma, I think. It's 4% of all malignant pediatric tumors, and 10% of those are in the orbit. You can see it in adults, but those are typically folks who are retinoblastoma patients and their status post-13. There are 4 major subtypes: embryonal, alveolar, pleomorphic, and sclerosing. Embryonal by far is the most common. And this includes that botryoid type, right? The grape-like clusters that you guys might remember from medical school. It also has anaplastic forms. Overall, as sarcomas go, it has a very good prognosis with a 5-year survival at 71%. Genetics here are very complex. They have a higher mutational burden, but there's no like knee-jerk, this is the diagnostic. Unlike alveolar, which has 2 different fish translocations that makes a fusion protein that we can test for. So they both involve FOXO1 gene, which is on chromosome 13. And then it's involving either PAX3 or PAX7. The fusion protein based ones are about 80% of the alveolar subtypes. It leads to RAS overactivation again. Tends to be a slightly worse prognosis than if they don't have that symptom. Pleomorphic is pleomorphic. It's a very small percentage. Do maths. It's what, maybe 5%, whatever the remaining percent is. And then sclerosing, that's one of the more unusual subtypes. Does not have a great knee-jerk fusion protein like alveolar does. There does seem to be some, in kids less than 1 year, there seem to be a couple of fusion products that they can see, but this is such a small percentage that are working on it. And then MyoD1 mutations seem to have a worse prognosis as well. So current testing for all our rhabdomyosarcomas of any site is to get FOXO1 fish, and we can look for the fusion products with that. And that will tell you if it's alveolar versus the non-alveolar type, and then you go based on morphology. And then COG has got, they do all of the pediatric tumor researches, big, huge studies. And so they're working on a gene expression panel here that might be able to stratify the non-fusion mutations to give you a better sense for how they're going to do. All right. So that's all of the kind of current snapshot of what we've got. The liquid biopsy is more of a future looking thing. So this is sampling for circulating tumor bits in the less invasive fluids, right? So if you could pick up their ocular melanoma in a blood draw, that would be preferable, right? A patient's going to let you draw blood. They say that aqueous humor is less invasive, although I feel like that's, like psychologically a little bit more invasive than a blood draw. But, it certainly is less invasive than like trying to cram it right into the tumor itself, right? So, and they're looking at all sorts of different tumor bits, right? So the tumor cells themselves can circulate intact. Maybe their DNA is getting spewed in your bloodstream. Maybe the RNA is, maybe their microRNA is. And then there's tumor-related exomes that you can see. And then tumor-educated platelets, which is new to me because then now they live in my head like this. And so based on the microenvironment, they tend to like pick up RNA. I guess they're real sticky, as you would imagine. And they pick up some of this debris and you can kind of, it changes how they act. And so lots of research is being done with this. Right now, there's FDA approval for lung cancer, so non-small cell lung cancer. You can try to look for these things in the bloodstream. Research is really focusing on uveal melanoma and retinoblastoma for you guys. Melanoma, particularly because of that early dissemination thing that it does, and then with the dormant cells, it'd be really great to be able to slam them with systemic stuff and knock those dormant cells out if you could, if you know that they're circulating around. Retinoblastoma is thankfully rare, and so the tissue source for their dissemination is rare. And so, could you test the aqueous humor? Because sometimes diagnosing these, that would help you with the differential of something like coats or before you give them intraocular chemo. For uveal melanoma, this is a nice review and cancers, and talks about the advantages and disadvantages of all these testing. When you see it say lack of consensus concerning pre and post analytic process, the issue with that is the biggest problem with this is not what they're looking at, but how you find what they're looking at. And so there's very few reliable processes that can pluck these circulating tumor cells or pluck the tumor DNA that's circulating around. There's a few that are approved and they say, well, they do pretty well, but there's a lot of concerns about them. I'm like, well, that's not pretty well. If you're making big cancer decisions on these things, you want it to be better than pretty well. So I think a lot of research has to go into figuring out how to find this information, find these particles. And then I think you're going to see this actually explode. But it seems very, very promising for uveal melanoma. Retinoblastoma as well, right? Like tissue diagnosis would be great, but there's risk of seeding, and so it's contraindicated right now. So if you could poke into the aqueous, pull it out, do next gen sequencing on the aqueous, and say, oh, there's a retinoblastoma mutation here, it will give you guys more confidence of what you're doing. Early studies are promising, small, very limited, so they've got larger studies underway right now. So that's all of the bits. I'm supposed to have a question. So here's my question for CME purposes. Which one? That one. Yes. Good. All right. So BRAF V600E is cutaneous melanoma. BAF1 is the one that we see in uveal melanoma. FOXO1 are in rhabdomyosarcomas, and the P16 are kind of perhaps in the squames of the surface. References for one. That's it. You guys have any questions? Yeah.
Does the liquid biopsy from bloodstream suggest metastasis, or is there comment on that?
It's a good question, like whether or not the tumor is not actually, and I think it depends on what you're looking at too. So like tumor DNA that's floating around doesn't have the capability of metastasis, but a tumor cell that's floating around very well might. And I don't think they've split that out yet. I think they're just trying to show. Certainly folks who end up having metastases in the studies tend to have more circulating tumor cells than people who ultimately don't have metastases, if that makes sense.
So the assumption is that, or I guess not, but the thinking is that if you have just tumor DNA, or even a primary localized uveal melanoma may release some circulating DNA without overt metastasis.
Yes, it can be kind of leaky, and just like the melanin pigment leaks out, you can imagine the DNA leaks out, and so it may not metastasize. And so looking at the burden, but the ones that are more likely to metastasize have higher burdens floating around, which would make sense. So looking at those, figuring out those thresholds is still under investigation, looking at the mutations of what they have. Some of these studies have said that they can tell the difference between a nevus, a uveal nevus, and a uveal melanoma, which would be really good to know, right? But those studies are very small, and these thresholds are very much researchy right now. But in the future, that would be so cool, right? To be able to do that and be like, oh, you've got you've got nevus. You don't have BAP1 mutations in your circulating cells. So therefore, we really think this is a nevus and will help guide your therapies and counseling.
That'd be great. We just had a guy who got enucleated about 6 months ago for a melanoma. Liver scans were fine, had his routine 6-month screening, 10 or 12 liver spots. So being a microscopic, metastasis or separating metastasis from just leakage, DNA or whatever.
Other questions or comments or anything? All right, you're free to go.